you try sharing, and appreciate everyone's patience as we're at 102. Let's wait for just a minute, making sure technically we're all okay. Looks clear on my screen. Is Simon's presentation clear, everyone? All right, we'll get started in a couple more minutes. Simon, can you hear me? Let's do some checking and testing.
Yes.
All right. John, can you hear us okay?
Indeed, yes.
Wonderful. All right. Welcome, everyone, to our special free preview webinar, Mastering the Art of Dental Facial Aesthetics. With me here today is my dear brother, Dr. Simon Wong, and a very special guest, Professor John Mew, the creator of Orthotropics. So my name is Kian Wong. You've probably been receiving a lot of emails from me regarding invitations and whatnot. So we're very excited to have you all here today. This is a special preview webinar. As mentioned, we're having a full 2-day introduction to postural orthodontics, where Professor John Mew will be one of 3 guest speakers. It'll be a full 2 days over a weekend on July 16th and 17th. Besides Professor John Mew, we have Dr. Perry Burston, ENT specialist, and Dr. Susan Shears, pediatric specialist, and of course the main lecturer being Dr. Simon Wong. That's coming up, as you can see here, on the weekend of the 16th and 17th. Moving on, next slide, please. And just a quick introduction. Hello. All right, if I may, Dr. Simon Wong is a leading expert in facial growth guidance, orthotropics, and early intervention orthodontics. He has held the position of visiting professor, co-director of the orthotropic module at the University of Valencia, Department of Orthodontics, and is a fellow of the International Academy of Dental Facial Aesthetics. The past 12 years as the principal of the Clinic Natural Smiles Centre based in Melbourne, Australia, he's been focused on the correction of early childhood craniofacial development issues, a devoted practitioner for the early correction of malocclusion. He's a published author of GOPEX, Good Oral Posture Exercises, with Dr. Sandra Khan, with journal and textbook articles on sleep disordered breathing, with his most recent article, The Jaw Epidemic: Recognition, Origins, Cure and Prevention in Bioscience. His current clinical research at the Orthodontic Department of the University of Alberta, and most recently at Texas A&M, under the supervision of Dr. Peter Bushang, will hopefully provide the pathway for the future of orthodontics to be focused on cures and prevention of all oral facial development issues for our children. Thank you. All right. And the special guest will be joining us a little bit later after the formal presentation is none other than Professor John Mew, the creator of Orthotropics. Professor John Mew, the creator of Orthotropics, graduated in dentistry at the University College of London and then trained in orthodontic surgery. Seeking alternatives to facial surgery, moved to the specialty of orthodontics in 1965. Since then, he's been pioneering and developing non-surgical methods of correcting unattractive vertical growth in children's faces using orthotropics to encourage horizontal growth. Practicing clinician, his principal research interests are the etiology of malocclusion and the guidance of facial growth. Currently, he's a retired professor of the London School of Facial Orthotropics and a visiting professor at the University of Medicine and Pharmacy, Timisoara, Romania. He was honored with life membership of the British Dental Association in 1999, if I may say so. Currently 94 years young. It is truly our great honor to have him speak at our event tonight and in July, in mid-July. So welcome, Simon, and welcome, Professor John Mew.
Hello.
All right. So Simon, let's see. Over to you, Simon.
So one of the most important things in my life was obviously the concept that the world holds mysteries, and we see only what's in front of our eyes, and we don't grasp that there are forces that apply in nature. And these forces allow us, if we pay attention, to learn a level of control that we believe was never possible because genetic inheritance didn't give us a say that our destiny was somehow set in stone. If we look to nature and try to understand biology, we can sometimes get a glimpse of how the micromechanics, the biological, physiological mechanics of the human body, if we pay attention, we can see that familial traits that seem to manifest in some, but not all our children, can't be explained by genetics alone. If we pay attention to how our bodies operate, not only when we're functioning, but also when we rest, we start to get a sense that the forces that affect our growth and development happen in the quiet moments of our lives. It happens when we rest and when we sleep at night. When we start to notice what we need for our body to heal, what we need for our bodies to grow, we can sense that there are certain things that help us. Our parasympathetic drive. See, we live in a world today where our focus in a race of ready, set, go is only on go. See, that terminology, ready, set, go, was a term that allowed us to prepare and focus before we exploded into action. Too often today, our focus is go, go, go. And we look at function and we think, well, if we can control how we function, perhaps we can control how our body develops. What we forget is when we are in movement, when we are in action, our bodies can only break down. Our cells can only expire. It's only when we rest that our bodies heal, that our bodies develop, that our bodies grow. And the most amazing thing that was taught to me in my 53 years of existence is when John said, your posture determines your structure. And I asked him, what do you mean, my posture? He said, how you rest your body forms the matrix of how it wants to grow. Because John is an orthodontist, his focus is in the mouth. And he explained to me, he said, you know, the top jaw and the bottom jaw, they are not paired structures. The top jaw is a big M that's stuck to the bottom of the skull. The bottom jaw are two L's fused together, joined to the tongue. And they actually have nothing that links them. The TMJ joint is actually attached to the temporal bone. So it's actually stuck to the side of the skull and it's not in any form of contact with the maxilla. So the only relationship these two completely different structures have is one of being neighbors. The top jaw and the bottom jaw are nothing other than ships passing in the night, unless we choose to rest with both jaws together. You see, the purpose of the jaws is to house the organ of the mouth. And the primary organ of the mouth is the tongue. For the tongue to be protected by the top and the bottom jaws, both jaws must encapsulate that organ. When both jaws encapsulate that organ, the jaws become one. And if we sleep with both jaws in close contact, then when that organ grows, two jaws that have no relationship other than sharing a boundary become unified. And when the top jaw and the bottom jaw sleep together, they become a brand new family. And they cannot help but to grow together in balance. I took John's words and I followed the progress of 155 children. And I used his principles and I used his appliances. And I created a record that explains John's tropic premise. So tonight, I'm going to talk to you about my journey in early intervention. I'm going to help give you a sense of what the difference between postural orthodontics is from other forms of early intervention. And I want to give you a concept of how I turned that idea that John seeded in my mind into a full-time practice that charges $9,000 to $22,000 in treatments without any form of advertising. And I want to share with you these concepts in our 2-day introduction course of postural orthodontics in the middle of July this year, on the 16th and the 17th. And tonight we'll be fortunate enough to share a conversation with Professor John Mew. So, how did I begin this journey? I'm actually Dawson trained. So I did my restorative dentistry with the concept of harmonizing muscle with bone and teeth. I realized when I was cutting a lot of teeth that when they weren't positioned correctly, I couldn't get the aesthetic results that I wanted as a restorative dentist. So I trained in traditional orthodontics. I used the, at the time, very, very new Invisalign aligner technology. I came across Chris Farrell's concepts on the MyoBrace, where he took John's concepts and principles and applied them into preformed appliances, which seemed to be very simple yet effective. My work in restorative dentistry led me to managing more complex cases and temporal mandibular dysfunction and airway concerns. I thought perhaps I should take a light hand. You know, the extraction and retraction that I learned in the conventional orthodontic processes seem to go against the principles of developing forward. So I learned about ALF light wire techniques. Dennis Stroken was my teacher from Canada. And then one day in my journey, I came across a very interesting book that caught my eye. And I bought this book and was surprised to find that there was a more interesting man behind these very interesting pages. So my journey took a shift in direction from functional dentistry, from fixed wire dentistry, from aligner technology, from MyBrace technology, to an idea that posture was the foundation of what drives good growth or bad growth. I found that when I traveled to see John, he had his views. And in the very beginning, I thought, I can't do what he does. Perhaps I can find other mentors that have modified his techniques. So I went to Los Angeles and I studied with Bill Hack. I went back to the UK and I thought, perhaps I can learn from Mike. So I flew and I flew and I flew. And for a decade, I racked up the frequent flyer points. Along my way, I took along with me my technician, Enrico Di Giovanni, who allowed me to get my hands wet and work with children using these concepts that John had taught me. And over time, I learned from my teachers and I began to make a difference in my community. I was scared. I was scared to use John's appliances. They seemed brutal. They seemed like they would penalize when compliance was not followed strictly. So I developed an easier way to explain the concept of posture. And I worked out that we had unwittingly been aware of posture for 10,000 years. We had unwittingly realized through the raising of our children, through the different cultural backgrounds of the West, of the East, from the North and the South, that each of our civilizations had very strict guidelines on how we would raise our children. We focused on teaching them to be well-mannered. We focused on teaching them to be able to communicate. And I started to realize that when we teach in our profession, we are mimicking what was taught to us in our childhood by our parents and by the people who raised us. I started to teach in Spain and Lithuania. I was fortunate to be able to share some of this knowledge at the University of Valencia. And with Sandra Khan, an orthodontist that I had encountered in my journeys, we developed an idea of how we collectively have been raising children and incorporate that into teaching the concepts of posture and how we use normal everyday manners to enforce good, strong posture. We went to Mexico and we taught probably the largest group of orthodontists that I've ever encountered in one sitting. We focused everyone's attention on tongue posture and malocclusion. We started to realize that throughout the world, people were desperate to learn how to cure malocclusion. even though everything that we had been taught was designed only to manage malocclusion. My fears of not being able to meet John's expectations drove me mental. It scared me. I knew I had to do what John told me to do, but I knew I couldn't afford to fail. So I made a decision. I was going to work within the system. I was going to create a practice and share this knowledge with parents and doctors who were interested. But I was going to do it within the confines of standard of care. So I researched and I looked into the references that we accept within our profession. And I formulated a 7-step framework of core values: prevention and position, oral posture exercises, structural rebalancing of the jaws, treatment planning, unwavered discipline, return on investment, and educate to motivate. Posture. The single most important concept to understand if we want to have any hope of managing and curing malocclusion. I use John's appliances. I use Bill Hang's appliances. I created my own appliances. And I combined that with the knowledge that our profession have already researched, that our profession had been using for decades. And we put together preliminary studies to see, how does this relate to growth and development? How does this relate to sleep disorder breathing? And we compared it to existing accepted functional appliances. And we found that we had skeletal change. See, when you have an A and B reduction of 3.5 degrees, we are making significant inroads. When we can close the vertical by 2 degrees, we know that we are no longer working within the realms of just moving teeth, but we are changing the direction of jaw growth. We had the University of Alberta take interest in orthotropics. We had Texas A&M, headed by Professor Peter Bushell, take interest in orthotropics. And they took my cases that I consecutively treated using John's methodology. And they have been, over the last 2 years, been evaluating and assessing the radiographic records over a 10-year span. And hopefully, we will be able to publish in the not too distant future our findings. One of the things that we have to also understand is, it's one thing to do research, but how do you turn this knowledge into something that becomes a clinical profession's objective? How do you take something that shouldn't be a hobby and create it into something that helps you develop a proper, profitable outcome? Well, the answer is You must have a mentor. You must have someone who can hold your hand and take you on this journey, which is not lit, which is not clear cut. We must develop trust within our practice and focus our energies on people who have already been a member of your clinical practice. See, when I first started, I treated children of parents that I had been looking after since their childhood. So they trusted me. They trusted me to take their own children on a journey that they had never heard of anywhere before. I'm hoping that if you join me in the 2 days that we have scheduled in July on a new evidence-based approach to early intervention orthodontics, that with virtual live streaming via Zoom, we can give you a glimpse into an unlimited possibility of allowing you to make a difference in your community, just like I have had the opportunity to make a difference in my community because of my professor, John Mew.
All right, Simon, thank you for that. All right, I'll just be very brief before we bring on John Mew. Hi, John. All right, if I just may have a couple of minutes here just to, while everyone's still here, people have asked about the event in July. Right now, we're what we call in the super early bird phase, so we have a huge discount. Regular pricing is $14.97, about 1,500 US or about 2,000 Aussie. But currently, you can get a ticket for just about 1,097 US. And it actually includes instant access to last year's recording. We had a 2-day event last year, very similar to this year's, but we had different guest speakers. We had Dr. Roland Barrowman, Max Fax surgeon, Dr. Sandra Khan, an orthodontist, co-author of GoPex with Simon. And this year, as mentioned, we have different guest speakers, including Professor Mew. But we wanted to make a very special offer for you to consider. A lot of you have already seen Simon at Derek Mahoney's EODO or seen some free webinars that we've hosted before. But if you make a decision tonight, and it all comes with a full money back guarantee until the end of July anyway, or the second day of July, you can get access to the recordings, right? As Simon said, we're looking to see whoever is really interested in this early intervention. We're going to give a significant $400 US discount. So it's not $14.97. It's less than half price. It's just $697 US. If you can just move to the next bit there, Simon. So, and we have a payment plan as well. You can spread it over 3 payments of $250. If you scroll to the next slide, please, and click again and again. So just simply go to straightteethnaturally.com/VIP-697. Now, this special will literally go away after midnight tonight. You got about 2 hours, and we will deactivate this link. It's currently at 1,097. We've just John was able to confirm his attendance just a few days ago. So we thought, let's make an irresistible offer, less than half price, 697. There's a payment plan of 3 payments of $250. All right. So you just go to that website, or you can email us if you can't. If you have any problems, email us at info@straightteethnaturally. I'll be here for the next few hours and give you the link in case, for whatever reason, that straightteethnaturally.com/VIP-697 doesn't work. And that's the pitch. All right, moving on. Let's see. I think we have John. John, are you there?
I'm absolutely there.
Oh,
sorry, I was dreaming away.
Dreaming away. Well, welcome again. Someone did quickly ask, you did the basic course already. Email us about the advanced program. We have a special for that as well. Just email me And John, welcome. It's such a great honor. It's the first time I connected with you just a few days ago. I've been hearing all about you. So I'm going to pass it on to Simon to share his story, interesting story of how he met you. Over to you, Simon.
So this is the link that bridged the meeting between John and myself. So on my journeys, I came across John's book, his magnum opus, The Cause and Cure of Malocclusion. About 15 years ago, I clicked on the website and I put in an order for this book. And I got an email confirming my purchase. And literally 5 minutes after that confirmation, I got an email from John Mew. And he wrote and said, "Oh, I see that you've bought my book. I would be very interested to read about what you think of it." And I replied, surprised. And I said, "Oh, you wrote this book?" And he said, "Yes." So, well, I will let you know what I think. And what I did was I read a chapter and I wrote to John and I asked him questions about the chapter. Then I read another chapter and I wrote to John again. And every time he wrote back and answered my questions. And this continued for about 6 months until I got close to the end of the book. And then he said, "Oh, Simon, would you like me to come and teach you?" And I said, "Yes." He said, "Well, why don't you organize to get a group of dentists together and I can fly over and I can teach?" And I said, "Well, that would be fantastic. When do you think you would like to come over?" And he said, "Well, I'm flying to New Zealand in 3 weeks, so why don't you have me over the weekend before?" And I fell off my chair. I said, "John, that's less than 2.5 weeks for me to organize." And he said to me, "Well, you're a smart young man, Simon. I'm sure you'll be able to organize something." And I did. In 2.5 weeks, I got 96 people, 96 dentists to come, paid $1,000 each. And that is the power of the name John Mew. I just put it out there to the world. I said, John Mew is coming to Australia. He's going to teach what he knows for 2 days. Would anyone be interested? And I got 96 replies within 2 weeks. You know, tonight when we put John's name on the webinar, we got 200 responses within 3 days. And it dawned upon me that someone great was coming to my hometown. And it literally changed the course of my life. To have John come and teach inspired me beyond anything that I can explain. And what I'm hoping to do today is allow you to access this wonderful book. Go to John's website, and please, if you don't have a copy of The Cause of Malocclusion, The Cause and Cure of Malocclusion, please buy it. So the website link is there, orthotropics.com, and then look for Cause, Cure, Malocclusion.
That's it, really. So, just go and let's stop sharing, Simon. I've included the link to where you can buy the book and the link to get our special VIP webinar special for the event. But let's just have a chat with John. Over to you guys. Oh, I think Simon's dropped off, but he will rejoin because his audio for some reason disappears when he stops sharing his video. We're going to get some technical support for that. All right, John. All right, Simon's back. All right, you back there?
Hi.
Yeah. You'll
Very
have
good.
to let me...
I have to let you turn on your video. We'll obviously fix all this technical stuff for the next one. All right, Simon.
So, John, one of the things that you inspired within me was for me to be able to make a difference in my community. You know, my focus in life was always about cosmetic dentistry. Until I met you, the only thing that really had any interest for me was cutting teeth and then recreating a smile using porcelain. And when I realized that that was an artificial approach to a natural problem, and you said to me, when beauty is developed within naturally, it is incomparable to anything that we can artificially create after the fact. And you explained to me that the power of posture will literally change the lives of the children that you treat. And I realized I didn't want to camouflage an ugly face. I wanted to cure it of the imbalances so that it presented in harmonious, natural, attractive state. The journey that I undertook is one that you've helped me over the last 10 years. And what I realized is there is only so much you can give to the world. It now requires dentists like Mike and myself to begin to take what you have given us and to continue to pass that on to the next generation and the next generation. What is your hope for these new dentists who perhaps have never come across your concepts and the ideas of the tropic premise? What would you hope for them in their future?
You're asking me what I would hope for in other dentists. It's an interesting question because really it's the patients I want to change. And the problem is that I have to teach the orthodontists how to do that. And most orthodontists have been traditionally trained to move teeth. And in fact, many orthodontists to this day think that their prime job is straight teeth. When I know, and I think you know, that faces are far, far more important than teeth. But of course, orthodontists genuinely don't believe that you can change faces. I'm amazed at that when I look at my own cases and yours, and the research you're doing now will clearly show that not only does growth change, but faces change too. Now, in the long run, I am absolutely certain that the public will go to the place where they can have better faces. They may like straighter teeth, but better faces matters far more.
The concepts are very difficult for people to grasp, that, you know, it isn't something that is inherited. The work that you've done over the last 4 or 5 decades has inspired many of us to attempt these changes. But it's hard to explain how difficult a journey it's been. You've been trying to pass this message on for 5 decades, and yet we still encounter the same resistance that you probably found on the first year of your teaching. We find it difficult to get the concept across. We find it difficult to be able to have parents explain the changes that are possible and what it is needed. Your work on Facebook has created a very large following of new and younger patients. What's your what kind of feedback can you give me about the enthusiasm or the misconceptions that people have in the lay public about posture and how faces may be changed by treatment, sometimes that orthodontic treatment provides?
Yes, you probably know that I have a considerable presence on the media, particularly Facebook and also YouTube. Traditional orthodontics went astray. Remember, it's over 100 years old now, and the original orthodontists used simply to move a few teeth to make them line up better. And orthodontics developed on that basis. And because most of them thought these were genetic, they never really looked into the background of the cause. And in my view, they use forces which are far, far greater than necessary. The force needed to move a tooth, or indeed the bone which is supporting it, is no greater than the force of a feather. That's 1 or 2 grams is just about right to move both the teeth and the bone. And that the force is used by most orthodontists today, certainly if they fit a straight wire appliance, is invariably about 20 times more than that, quite often 100 times more than that, and not infrequently greater even than that. That is why root damage and indeed root resorption is not just occasional, it is endemic. It goes with every patient who has fixed appliances. There are no exceptions. It was working through posture that I realized that we must not use heavy forces. And if we want to change faces, we need do no more than change the position of the tongue, the lips, and the jaw. Just the position, no force. Many people perform what they call mewing, which is applying forces from the tongue and lips and jaw, and they talk of pushing and pulling, but no force is involved in natural facial growth, minimal forces. And I think that that is probably the most important lesson that orthodontists need to know. But as far as your comment on what the patients want, they do want beautiful faces. And there is no doubt that a good-looking face will earn you a better income, a higher status, a more attractive partner, and many other benefits, whereas an unattractive face will mean you drop into the lower income groups and you have less success in life, and indeed, you are more likely to commit suicide. These are all published facts, and no one would dispute them. But you are right, the orthodontists object to my suggesting that they should try another way to the one they were trained at university.
Yes, it's very, very difficult for everyone within and without our profession to differentiate between function and posture, and how functional changes don't affect your natural development. Only your resting position appears to affect your natural development. Sometimes it just needs to be explained in a way that takes the focus off the busyness of our attention and allow everyone to just quieten down and to let the body grow in the direction that allows everything to fit in its place with its own space. We have so much to learn from your concepts, but applying that knowledge in a day-to-day practice has been very difficult. Very few people practice exclusively full-time in growth guidance, in orthotropics, in any form of posture-related practices. Too many clinicians dilute the concepts because they're too busy, they've got too many overheads, there's too many things going on. So hopefully we can find a way of bridging that gap between what is possible with orthotropics, but all the baggage that's involved with orthotropic practice, and connect it to normal practice and allow people to move at a pace that suits their situation, but allows them the opportunity to continue to help the children that they are looking after, but not necessarily at their own expense, because I think that is what's been holding up a lot of the progress in orthotropics.
Sorry, were you asking a question in particular?
So you've been fortunate enough to travel to every corner of the world to teach. The welcome that people have given you has been warm, but there has been slow progress. What do you think might help the clinician who's interested but afraid to take the next step to actually work on children?
Right. I think it's natural, Simon, that when you hear of a new method or technique, bits of it impress you and you think to yourself, oh yes, I'll do that, and maybe I'll do that. And orthodontists and dentists are very inventive people. I find very, very few of the many people I have taught actually do as I suggest. They all do it their way. And a lot of them still tidy up with fixed appliances, which I actually think always cause damage. But I think the biggest failure is for them to take the face forward enough. I think you are very good at this, but many people do not follow the indicator line. That is the perfect method of deciding where the maxilla is positioned. If it is correct, the maxilla is in the right place, but it is very rare for it to be correct. And as the indicator line increases, the faces look worse and worse. And the thing I think matters most is correcting that. Lots of people advertise themselves as orthotropists, but what they do is way different from what you or I would do. And a lot of them, I think, do a lot of harm. And yet the public have no way of understanding this. One day, orthotropics will be taught in universities, and then a qualification can be given which is specific. But until then, I'm afraid a large number of dentists will simply say, I do orthotropics. And when the patient goes, they find that they're having their teeth put into line with fixed appliances.
Yes, absolutely. So hopefully what we want to be able to do is share some of the teachings that you have provided me, where I've been able to create a system where the dentist who wants to start this journey can begin and not become veered off course and distracted. So hopefully, when we meet up again in July, some of those who have given us their time tonight to listen to me and you, hopefully we can begin to give a little bit more of the information that is going to provide the framework for the dentist who wants to make this difference, create a practice that is safe for them, safe for the children, and to take the concept of posture and bring it into creating a change that is positive for the patients that they look after. So I wanted to thank you, John, for taking your time tonight or your afternoon in the United Kingdom to share some of the knowledge that you've developed over many, many decades. And hopefully there will be dentists who have listened to us tonight. We'll be seeing them again later to talk a little bit more about how we can get what you have created into the hands of the many doctors out there who are showing this type of interest in looking after the children there under their care.
Wonderful. Thank you, John. Thank you, Simon. Don't disappear just yet because we do have some questions. John, could you be possible to stay an extra 10 or 15 minutes to answer some questions? We have 140 folks who joined today. So we have a question from Kevin, if I may read out. What if a reluctant 3 to 5 year old child who might be in dire need of orthotropic intervention will not open his mouth in your dental chair and or display some other forms of obstinance and age appropriate uncooperation, often seen in novel healthcare settings? So Simon or Professor John?
Yes, I didn't hear all of that, but essentially you've got a 5-year-old who's got their mouth open. I would emphasize that an open mouth posture does much more damage than anything else. I'm always talking about correct tongue posture, but actually, if you leave your mouth open, you'll wreck your face anyway. So the first priority is to get the mouth shut. Now, many parents keep telling their children, shut your mouth, and the child does it for 5 seconds, and then the mouth is open again. But it has to be continuous. And I don't think parents realize how important this is. I said, if I wish to get a child to keep their mouth shut, I have a big stick, and every time their lips are apart, I hit them on the head with it. Now, maybe that's partly in jest, but it does make the child keep their mouth shut, and without doubt, they will then grow up to be attractive. So it really matters. I mean, you can give them treatment, and indeed, Simon or I would give them an expansion appliance and help to teach them to keep their mouth shut. But all you need at the age of 5 is a big stick.
So Kevin followed up.
Yes, so Kevin was asking, if a child doesn't cooperate and won't even open their mouth.
Sorry, the picture, now I'll move it. I can't see your lips, therefore I can't hear. That's better. Okay, carry on.
So I think the question was, how do we get young children to cooperate?
Well, I think that is a great problem. Simon, I have always had this problem. There's no doubt that timing devices make a huge difference. If I give someone a stage 3 appliance to teach them to keep their mouth open, I expect them to wear it 20 hours a day. But using a timer, you can check that. But without using a timer, I'm usually finding it's 6 or 8 hours a day. Posture needs to be continuous for it to make any difference, and therefore timers are essential. Interestingly, out of all the patients I have had, the ones who've been told they need surgery cooperate best. It's very simple, but the reason is that if they don't wear it enough, I say, well, it looks as though you'll have to go and you have your jaws cut. And then immediately I have a bit more enthusiasm. But of all the patients I have treated who were told they needed surgery, only one of them actually failed. And that's an amazing statistic.
So one of the things, thank you, John. So one of the things that everyone is always interested in is, well, how do we develop the relationship with a young child so that we can have them cooperate with us to take records, to sit still in the chair, and to be part of the treatment process? And my answer to that question is, it's actually not up to us to develop that relationship with the 3 or 4-year-old. It's actually the job of the parents to raise their child in a way that has them understand the concept of social interaction. So, when we have a very young child who is frightened or isn't able to feel comfortable, then we have to spend time with the parents and say, hey, you've got to spend time with your child and get them ready for this opportunity, because this opportunity has only a small time window. Right? There's only a few years available for us to make a difference. And if you want us to help your child, you have to prepare your child at home to be ready to interact with us. So it's not about us finding a way to convince the child to cooperate. It's us explaining to the parents that it's their job to prepare their child for society. It's their job to prepare their child to be comfortable interacting with us and to be cooperative with us. And if the parents don't have the maturity to be able to help their child develop that maturity that is needed to interact with us, then they're not ready. And we can't help people who aren't ready.
You're right, Simon. I would say get a bigger stick. But in reality, I think the stage 1 appliance is usually fairly simple, just merely enlarging the upper jaw. The problem becomes when you wish to change their posture. And of course, I rely on the stage 3 appliance. And once you learn to get the locks right, and when you fit a timer, and you are sure they're wearing it for 20 hours a day, treatment goes automatically. There is no problem.
Absolutely, John. We have taken too much responsibility. See, we've taken on the responsibility that we have to provide a perfect outcome. Our fillings have to be perfect, the crowns have to be perfect, the smile has to be perfect, and if we do orthotropics, the face has to be perfect. And we forget it's actually not our child. It's actually not our child. It's the parent's child. And if they want their child to develop well, then they have to take on the responsibility of ensuring that. But we can coach them in the right methods to do so. So cooperation really is a concept that the parents of our patients have to understand. Very good. Are there other questions, Ken?
Yes, thank you, Kevin, for your question. And we have another question. Hopefully that answers your question. We have another question from Georgina. At what age do you consider it too late for growth guidance or early intervention? Obviously, any age we benefit from tongue retraining, changing from mouth to nasal breathing, etc. But what age do you consider too late, John or Simon?
I spend my time on Facebook answering adults the same question. I tell them essentially it depends on the severity of the problem. It depends on their willpower and the time they're prepared to spend. But growth obviously slows as you get older. After puberty, it slows considerably, but the mandible will still be able to grow quite easily up until the age of over 20, often 25. After that, forward mandibular growth is very slow, but it does take place. In fact, all the adaptations continue throughout life. Obviously, growth stops soon after puberty, but bones will change until you die. You can see this if an old man develops a stoop. The shape of the spinal bones will completely change shape, not a little bit, but a huge amount. So this adaptation is possible throughout life. But of course, you have to change posture permanently. And I find most adults, I was almost unable to do that. What amazes me is that a few do. I had a 30-year-old the other day who sent me a photograph of himself after 1 year of correcting his own posture. And there was quite a large change.
So one of the things that I teach in this program is how do we create a safe, predictable, consistent outcome for our practice? Because, you know, if we were doing fillings or crowns, and if every second filling or crown fell out, how many fillings or crowns would we be comfortable doing? If every third filling fell out, would that make us more comfortable? Would we be okay, for example, if only 1 out of 100 fell out? Now, the more consistent our outcome, the more likely we're going to practice that discipline. If we pick patients that are outliers in the growth, then we run a much higher risk that we will not have any outcome that is considered successful. So my recommendation is that we stick to children who are still in the mixed dentition. Then we have a much better chance of providing consistently reproducible outcomes. John taught me a slogan many, many years ago, and his slogan was 8 is too late. And if we're dealing with severe imbalances, if we haven't started treatment by 8, then we will never fully correct the imbalance.
I think that's a fair statement, Simon. And I still believe what I said then. But of course, life is never black and white. Many people have posture which is just slightly wrong. Others have posture which is very badly wrong. But I have no doubt in my mind that it is the posture which determines the severity and the age which determines the ease of correction. So I do actually say that if you can develop perfect posture, and that's a dream, then you will have a perfect face if you start at the age of 8, or you'll have quite a good face if you start at the age of 20. And even if you start later than that, your face will look better. And another point we've not discussed is your health will be better, because people with correct posture breathe through their nose, and they're fitter and better and live longer.
Absolutely. It's degrees of change that's possible. You know, changing posture for jaw growth guidance is a physical discipline. If we want to take someone who has very poor form and develop them into an attractive form, then we have to consider how many years of disfigurement are we trying to reverse. And if they're 20, then we would say we have to reverse 20 years. If they're 10, we might have to reverse 10 years. If they're 8, we might have to reverse 8 years. Now, puberty tends to set the bones into a much denser, harder form, much more difficult to change. So I know through my own experience, growth changes that I have to instigate take me 4 years to really make a change to a child's posture. And I know that if I don't get 4 good years before puberty, I'm going to struggle, which is why I tried to follow John's 8 is too late rule. And I would implore those who are starting this journey to really consider that as a very important milestone. The more experienced you become, the greater your range of adaptability and understanding, and your consistency of improvement will increase with severity and increase with age improvement. So when you're first starting, you should try to stick with primary dentition or early mixed dentition as your starting point. So next question, if there are any.
Yes, actually, we had someone raise his hand. Stuart Watkins, are you still here, I believe? Would you like to submit a question, or if anyone wants to join the panel in the last 5 or 10 minutes of this, happy to, if you want to speak.
We might start to wrap it up. So maybe 2 more questions.
Yeah, 2 more questions. Stuart, if you want to ask a question, or let me just.
Or anyone else?
If you want to join the panel, just have a question directly with Professor Mew, feel free to raise your hand. Otherwise, we shall wrap up if there's no more questions.
Excellent. Will you
let me just share if you could share the screen again. So we're waiting for the last couple of questions, if there are any. But if you could share your screen, Simon, I'll just show again on the screen for everyone this special that we have. A few people have asked about the different programs and so on. Can you share your screen, Simon?
I'm just going to.
Well, thank you, John. I don't think there are any other questions. Nothing's coming through. So thank you, John, so much for joining us, and in late mid-July as well. We're very excited to have you on day 2, I believe. The beginning of day 2 is a good time that starts at 7 a.m. Melbourne time on Sunday, which, depending on your time zone, you'll have to check. Simon, can you share your screen, please?
Right. Well, goodbye, everyone.
Thank you, John. Take care. Thank you
so much, John.
Terrific. So just for those who are interested, happy to answer questions about Simon's program. A few of you have asked. A few of you had some problems registering, so I've put the link again. So if you can click on that, Simon, a couple of times. Let's. Are you there, Simon? There we go. Full screen. And click. There we are. So if you have any question, can you go to the next? That's fine. Let's just leave it there for now. All right, so we have an event in mid-July, 16th and 17th of July. It starts at 7 a.m. Thank you, Samira. And the regular pricing is $14.97, just short of $1,500 USD. But right now, we're in what we call super early bird, so it's only about $1,100 US. But we have what we're trying to do is just look, if you've been on the fence and you're not sure whether it's for you or not, let's make it irresistible just for tonight only. So another 1.5 hours, we'll actually disable this link, straightteethnaturally.com/VIP-697. Put that in the group chat there. And it's just $697. It's less than half price. So $697 US dollars. It's short of a 900 odd Aussie. Or you can do 3 payments of $250 if that's more convenient. The details of this event, you can go to just straightteethnaturally.com if you want to read through things a bit more carefully before you make a decision. But you've got until midnight tonight, Australian time, which is in about an hour and a half's time. So if you have any questions now, please feel free to submit them in the chat box and I'll answer them. So what do you get for this VIP ticket that we're giving the special on? Well, you get the 2-day event and it's recorded. So you will get the recordings end of July. You'll also get instant access to last year's 2-day event, which we held in July also. It's an annual thing. We had different guest speakers. We didn't have John, but we had, as mentioned, Dr. Barrowman and Dr. Sandra Khan. Dr. Barrowman is a MaxFac surgeon, and Dr. Sandra Khan is the co-author of GoPEX. So you get instant access to those recordings. It's about 20 odd hours. It includes some bonus Q&A sessions we did previously. So there's an additional 3 or 4 hours. I think in total is about 24 hours of content, plus practice manuals, plus the actual slides of the event. And for those who are experienced in this area, can run with it. You know, we go into details about the appliances and so on. On that note, good night. Take care. I hope you guys enjoyed the presentation, and we'll see you hopefully inside our closed Facebook group. Good night, Nina. Take care, everyone. Ciao.